Thank you, Enrique, for those insights and, as you said, provocations. Can I invite questions or comments, responses, or rebuttals? Yes, Ramanan.
So you mentioned in the gaps about first of all, that was a really great overview, and obviously we don't get to hear from people who actually do this stuff on a day-to-day basis. So that was a very helpful insight. In terms of gaps, you talked about creating an enabling environment and that being something that was important. But could you expand a little bit on how that happened in the context of Mexico?
Yeah, I think that in the case of Mexico, it took many years enabling the environment. Let me explain why. For example, we were aware that people were really unsatisfied with health services in Mexico. And the reason we knew that was because well, let me start by saying the strategy, the national strategy started in 2000. Well, we knew since 1994, through a national survey, that the population was really, really unhappy with the services. So a few years later, we had done several assessments on technical quality, and we knew the gaps there as well. So creating the environment for a large-scale change may take years. It's not just a matter of having a couple of conversations with a few leaders and convince them. You need data, you need political will, and let me tell you that in the case of Mexico, again, we were very fortunate because the president of Mexico at the time, the newly appointed or elected president, had been chairman of Coca-Cola. So he understood what quality meant. And it's an interesting story if I tell you that when he asked to all the areas of government to propose the key projects from the health area, there were two proposals. One was is now called the popular insurance, the extension of the coverage, financial coverage, and the national strategy for quality improvement. And he said, well, let's think about the popular insurance. Quality improvement, yes. He was the leader in the presentation of the strategy, with unions, with colleges, with academies, with professionals, etc. So it's a matter of timing, and I would say it's a matter of taking the opportunity as well.
Enrique, thank you for that. Can you spend a couple more minutes talking about one of your earlier points about the question if the individual processes or locations are improving, does that mean the system's improving? I don't quite get the point. I think it sounds important to me.
Yeah. Let me then go back again to the example of Mexico, which is the one that I know. What would have happened if we decided to improve the quality of 10 hospitals and we didn't have a large-scale strategy? What does that mean in terms of the system-wide strategy? It meant that we had to create a message for the whole country, not only for the 10 units, or the 20 or the 40 units. We were working, by the way, with 6,000 units. But you have to create a message. You have to create the incentives for the whole system. So by the time you start working with some units, you can spread easier. So that's what I mean, just with this couple of examples, that by improving one unit and the other, not necessarily get you get to that point. But then let me add another consideration, again, in terms of continuity of care. Let's think of a diabetic patient that has to go or has to move between primary care and hospitalization. And you may work with the hospital, you may work with the primary care unit, but there is a gap in between, and the patient has to come back and forth. So if you don't think in that system as such, that's what I mean.
Thanks, I enjoyed the talk. Can I just ask one question, and, well, two questions. You talked a lot about government, but you've just hinted at the role of other players in the whole quality arena. I'm particularly interested in the sort of, you mentioned professionals, unions, et cetera, and I'm just wondering how important they are to really make change. In our setting, we have a relatively policy-rich but implementation-light government with lots of autonomy at local level, not necessarily by design, and so there don't seem to be too many guarantors of quality. And the second question stroke comment is that we're seeing an increasing amount of investment in management training to actually quite a large degree, but it tends to be focused on 2-month course somewhere, highly didactic training, no follow-up. And I'm just wondering on your thoughts about what you mean by management training. Is it management mentorship or sort of diploma-type training?
I didn't went into detail on the professionals and other actors because we spent a lot of time yesterday with that. And to me, the one of the gaps was, again, working with governments. So that's why I spent more time with that than with the rest of things, because we were talking yesterday about professionals and the importance of local development. So I didn't want to say anything else of all the things that we heard yesterday. But of course, they are absolutely necessary. So you cannot do anything downwards if you don't create the opposite movement. So we know that, and it's absolutely necessary. Then management training. Gary Filerman wrote an article several years ago talking about the programs in public health, which are off target when you try to develop managers. Gary, you can correct me if I'm wrong, but this large or long programs are not very well focused, are not very useful when you have to deal with the day-to-day operation of services. I'm not talking about then master programs or master's programs. I'm not talking about large diplomas. I'm talking more on very focused training with mentorship, of course. It's not something that you just learn in 2 weeks and you're... But certainly we have to make clinicians, particularly, understand what we are talking about. Because otherwise my concern is that the language is different. When you talk about implementing quality improvement, even the word implementing might mean different things.
For one more question or comment? Yes, Edgar.
Yes, something very brief. 25 years ago or more, I was a provider in rural areas in my country, and I was director of hospitals. And my impression is that we talk about how the turnover of people in the facilities affects our programs. I wanted to know your opinion about something. What about the turnover here among us? I don't know if it's a physical turnover, mental turnover. Why I say this? Because many of the questions that we are trying to solve here were the same questions that we had 25 years ago. So have we been unable to respond them? Or maybe we are trying to respond them in the wrong way, or maybe they are responded in another way. So I just wanted to know your experience in that regard, or your reaction.
I don't know if I understood well, but I think that turnover is a fact. and sometimes we would like not to exist, but it exists. So I think that we have to learn how to deal with it, and I don't know how to do it. But this is something that we have to learn. And this is something that we have to take into consideration again when we assess the impact of interventions, because it might depend on the history of the organization and the turnover. I was wondering once that we might start talking about these interventions with, and preparing and training people as if they would be, at some point in time, the leaders in the organization. So by the time someone of them arrives, they already know what to do and not break the continuity of leadership, which of course is not easy. Sometimes it's not possible. I mean, it's just a dream sometimes. So I have no answer to that, but other than saying we will have to learn somehow how to live with turnover.